Welcome to the Deep Dive, the show designed to equip you with a profound understanding of complex, crucial topics. Today we're embarking on a deep dive into two incredibly powerful classes of medications, antipsychotic agents and lithium.
Right.
These aren't just fascinating molecules from a pharmacological perspective, they represent monumental shifts in how we understand and treat some of the most challenging brain disorders, profoundly impacting countless lives and pushing the boundaries of neuroscience.
Exactly. Our aim today is to go beyond the surface. Understanding these agents is essential because they mark a historical turning point in mental health management, moving us from an era of long-term institutionalization to one where community care is often possible. Moreover, their very existence has fueled scientific inquiry into brain disorders, providing invaluable tools for researching the intricate ways conditions like schizophrenia and bipolar disorder manifest in the brain. By the end of this deep dive, you'll possess a nuanced understanding, truly mastering this information like an elite professional in the field.
To really ground our discussion, let's begin with a powerful real-world scenario. Imagine a 19-year-old college student, a young person at the cusp of adulthood, brought into the clinic by his worried mother.
Okay.
He's behaving erratically, his actions are completely out of character. He destroyed his TV because he genuinely believed it was sending him harassing messages.
Wow.
He's refusing to eat, convinced his own family is trying to poison him. These are classic, deeply disturbing signs of a profound disconnect from reality, what we call psychosis. For this young man, a diagnosis of schizophrenia was made, and that marked the beginning of a challenging journey into medication management. We'll revisit his story as we unpack the science behind how these medications work, highlighting the profound and often devastating impact such conditions have not just on the individual, but on their entire family and support system.
With that powerful real-world picture in mind, it's clear we're dealing with profound conditions. Our mission for this deep dive is to empower you with a comprehensive and nuanced understanding. We're going to explore the precise definitions of these conditions, the underlying brain hypotheses that inform our treatments, how these drugs work at a molecular level to restore balance, their diverse uses beyond the most obvious ones, and the critical considerations of side effects and comprehensive patient care. By mastering this, you'll be able to engage with this topic with the depth and insight of top professionals in the field.
So to really get a handle on the treatments, we first need to define what we're actually treating. What exactly is psychosis, and how does that differ from schizophrenia?
Okay, good question. Psychosis isn't a standalone disease. It's more of a mental state, a constellation of symptoms characterized by a profound inability to distinguish between what is real and what is not.
Okay.
Its hallmark features include delusions, those fixed, false beliefs that are resistant to reason or contradictory evidence, and various types of hallucinations. While auditory hallucinations like hearing voices and visual hallucinations are most commonly described, they can also involve touch, smell, or taste. Critically, these symptoms occur in a clear sensorium, meaning the person isn't disoriented or confused due to, say, a fever, drug intoxication, or head injury.
Right, they're fully awake and alert, but experiencing these things.
Exactly. Think back to our 19-year-old. His belief that his TV was sending him harassing messages is a clear delusion, and hearing voices about poisoning is a classic example of an auditory hallucination. These perfectly illustrate those core features. Now, schizophrenia is a specific kind of psychosis, though it's important to remember that psychosis itself isn't unique to schizophrenia. Other conditions can cause it too.
Got it.
Schizophrenia is primarily characterized by that clear sensorium, but with marked disturbances in thinking and perception. It's the most common psychotic disorder, affecting about 1% of the global population.
Which is a huge number when you think about it globally.
It really is. This seemingly small percentage translates into a massive public health impact, as schizophrenia is responsible for approximately half of all long-term psychiatric hospitalizations. And while psychosis is a feature, not all patients with schizophrenia experience psychosis at all times. They can have periods of remission.
So it's not a single simple thing, but a spectrum of symptoms. And it sounds like we're not just talking about a mental issue in the abstract, but something profoundly rooted in the brain itself. Is that the most current thinking?
Absolutely. That's precisely the consensus now. Schizophrenia is now firmly recognized as a neurodevelopmental disorder.
Okay.
This implies that structural and functional changes in the brain are present, potentially even from early development in utero, or they emerge and unfold during childhood and adolescence, essentially indicating a fundamental issue with the brain's wiring and development. This understanding is powerfully supported by extensive genetic research. Twin, adoption, and family studies have firmly established a high heritability for schizophrenia, meaning it often runs in families.
But not simple genetics, right? Not like one gene causes it.
Exactly. It's not due to a single gene. Current theories point to a complex interplay of multiple genes, including common and rare mutations, as well as large deletions and insertions in DNA, known as copy number variations.
Okay.
This complex genetic mosaic is a major factor in the diverse clinical presentations and varied courses we see in individuals with schizophrenia. It's very heterogeneous.
That's a powerful foundation. So how did we even begin to tackle such a complex brain-based disorder pharmacologically? What was the real breakthrough that genuinely transformed the landscape of mental health treatment?
Well, the initial breakthrough arrived in the 1950s with the discovery of agents like reserpine and chlorpromazine.
Chlorpromazine, right, Thorazine.
That's the one. These were the very first drugs found to effectively reduce psychotic symptoms in schizophrenia. Reserpine had a brief moment, but quickly faded, and it's not relevant as an antipsychotic today. Chlorpromazine, however, was a genuine game changer. It was identified as a neuroleptic agent.
Neuroleptic meaning?
A term that refers to its ability to produce catalepsy, a trance-like state with rigidity in rodents, and, crucially, to cause extrapyramidal side effects, or EPS, in humans at its clinically effective doses.
Ah, the movement side effects.
Precisely. This was a critical observation because its antipsychotic action was directly linked to its ability to block dopamine, or D receptors in the brain. This foundational insight made in the 1950s then opened the floodgates for the identification of many other compounds as antipsychotics over the next 2 decades. But the truly transformative moment really came with the discovery of clozapine in 1959.
Clozapine, that's a big one.
Huge. This drug fundamentally challenged the prevailing dogma because it demonstrated for the first time that an effective antipsychotic did not have to cause significant EPS at clinically effective doses.
Right, so it broke that link.
It did. Clozapine was quickly dubbed atypical precisely because of this unique dissociation between its antipsychotic efficacy and the absence of those debilitating movement side effects. This became the defining characteristic of what we now call second-generation antipsychotics.
Okay.
As a direct result, there has been a profound shift in clinical practice away from the typical or first-generation drugs toward these atypical or second-generation agents, which offered not just fewer EPS but other advantages too. Well, potentially better effects on negative symptoms, cognitive issues. We'll get into that. But the introduction of these antipsychotics, particularly the atypicals, led to massive changes in how mental illness was managed, famously contributing to the widespread move from lifelong institutionalization to shorter hospital stays and community-based care for many patients.
A major societal shift.
Absolutely. These drugs also proved invaluable as research tools, allowing us to delve much deeper into the actual pathophysiology of schizophrenia and other psychoses. And what's truly fascinating is that many experts now view schizophrenia and bipolar disorder not as completely separate entities, but rather as part of a continuum of brain disorders that share psychotic features, indicating a deeper shared biological basis.
This is where it gets truly fascinating. To understand how these drugs actually work, we need to dive into the competing and often complementary theories about what's fundamentally going awry in the brain. Let's start with a classic. The dopamine hypothesis.
Okay. The dopamine hypothesis of schizophrenia, despite its limitations, remains incredibly relevant.
Yeah.
It's still our primary framework for understanding the major dimensions of schizophrenia, the positive symptoms like hallucinations and delusions.
The more active symptoms.
Exactly. And the negative symptoms such as emotional blunting and social withdrawal, and even the cognitive impairment and sometimes accompanying depression. Crucially, it's foundational for understanding how most, if not all, of our current antipsychotic drugs actually exert their effects. There's compelling evidence pointing to excessive dopamine activity in specific brain regions, particularly the limbic system, as a key driver of psychosis. Firstly, almost all effective antipsychotic drugs strongly block postsynaptic D2 dopamine receptors in the brain, especially in the mesolimbic and striatal frontal systems. This even includes newer partial dopamine agonists like aripiprazole.
Okay.
Secondly, drugs that increase dopamine activity, such as levodopa used in Parkinson's or stimulants like amphetamines, can either worsen existing psychosis or, in some cases, even induce it in healthy individuals.
That's a strong link.
It is. Thirdly, postmortem studies of brains from untreated individuals with schizophrenia have found an increased density of dopamine receptors. Fourthly, some studies have also reported higher dopamine levels and D2 receptor density in areas like the nucleus accumbens, a key part of the brain's reward system. And finally, advanced imaging studies show increased dopamine release in response to stimulants and higher baseline occupancy of D2 receptors in key striatal areas, all consistent with a dysregulated, overactive dopamine system. However, and this is a big however, the dopamine hypothesis is far from a complete explanation, especially when we look at the cognitive impairment often seen in schizophrenia.
Right, doesn't explain everything.
Not at all. In fact, current thinking suggests that while excessive dopamine in some areas contributes to positive symptoms, diminished dopamine activity in other cortical or hippocampal regions may underlie those challenging cognitive and negative symptoms.
So too much in one place, too little in another.
Sort of, yes. Studies have shown decreased dopaminergic connections in areas like the prefrontal cortex and hippocampus, which are vital for functions like working memory. Imaging studies have even linked increased D1 receptor levels in the prefrontal cortex with working memory impairments.
Interesting.
And the very effectiveness of atypical antipsychotics, which have less of a direct D2 receptor effect but still work, has shifted our focus. We're looking at other dopamine receptors and, significantly, to non-dopamine systems, especially serotonin.
Serotonin again?
Yes. The 5-HT2A serotonin receptors, for example, may have synergistic effects, perhaps even protecting against the extrapyramidal side effects that come with D2 antagonism. So the cutting edge of research is now focusing on compounds that act on multiple transmitter receptor systems, primarily serotonin and glutamate. What's truly fascinating is that atypical antipsychotic drugs consistently share the property of weak D2 receptor antagonism combined with a more potent blockade of 5-HT2A serotonin receptors that seems to be the real key to their unique profile.
So dopamine isn't the whole story. What about serotonin, which we often associate with mood? How does that fit into the picture of schizophrenia?
Well, the serotonin hypothesis has a really interesting backstory. Early research into indole hallucinogens like LSD, which are serotonin or 5-HT agonists, initially led to this, ultimately fruitless search for similar hallucinogenic compounds naturally produced in the brains of schizophrenic patients.
Like an endogenous LSD.
Kind of, yeah. That didn't pan out, but the truly pivotal discovery from this line of research was the realization that the hallucinatory effects of these agents were largely mediated by stimulating the 5-HT2A receptor and possibly the 5-HT2C receptor as well.
Okay, so the hallucinogen connection pointed to serotonin receptor.
Exactly. This was a breakthrough because it led to the understanding that 5-HT2A receptor blockade is a key factor in the mechanism of action for the main class of second-generation antipsychotic drugs, with clozapine being the prototype. These drugs act as inverse agonists at the 5-HT2A receptor, which means they don't just block the receptor, they also suppress its baseline or constitutive activity.
Interesting. So they turn it down even further than just blocking it.
Precisely. These receptors are incredibly important because they modulate the release of a wide array of neurotransmitters, including dopamine, norepinephrine, glutamate, GABA, and acetylcholine, across critical brain regions like the cortex, limbic system, and striatum.
Wow, they're really central players.
Very central. Furthermore, stimulating 5-HT2A receptors leads to the depolarization of glutamate neurons and stabilizes NMDA receptors on postsynaptic neurons. There's even evidence that hallucinogens specifically modulate a complex involving both 5-HT2A and NMDA receptors, highlighting a deep functional connection between these systems. And the plot thickens with 5-HT2C receptors. Their stimulation provides another way to modulate cortical and limbic dopamine release, specifically by inhibiting it. Many atypical antipsychotics, such as clozapine, acenapine, and olanzapine, are actually 5-HT2C inverse agonists, meaning they block this inhibitory effect. In fact, researchers are currently studying 5-HT2C agonists as potential antipsychotic agents themselves, pointing to the multifaceted and evolving understanding of serotonin's crucial role.
Beyond dopamine and serotonin, what other major players are we looking at in the brain chemistry of schizophrenia? Is there a newer frontier in this research?
Absolutely. The glutamate hypothesis represents a newer, incredibly exciting frontier in understanding schizophrenia. Glutamate is the brain's primary excitatory neurotransmitter, absolutely essential for processes like learning and memory.
Right.
The critical link here became clear through the effects of drugs like phencyclidine or PCP and ketamine.
The dissociative anesthetic.
Exactly. These drugs are non-competitive inhibitors of the NMDA receptor, which is a type of glutamate receptor. Crucially, in patients with schizophrenia, these drugs don't just worsen psychosis, they also significantly exacerbate cognitive impairment.
Okay, that's a key observation.
It is. In animal models, PCP and related drugs are widely used to create models of schizophrenia-like symptoms precisely because they induce increased locomotor activity and cognitive impairments. Interestingly, selective 5-HT2A antagonists, which are key to atypical antipsychotics, are much more potent than traditional D2 antagonists at blocking these negative effects of PCP and related compounds.
So the serotonin link comes back again.
It does. This observation became the foundation for the hypothesis that hypofunction, meaning underactivity of NMDA receptors, specifically those located on GABAergic inner neurons, is a core contributor to schizophrenia.
So underactive NMDA receptors on inhibitory cells.
That's the idea. If these NMDA receptors aren't functioning optimally, it leads to diminished inhibitory influences on overall neuronal activity. This reduced GABAergic inhibition can then lead to a disinhibition of downstream glutamatergic activity, which in turn can result in hyperstimulation of cortical neurons via other types of glutamate receptors. It creates a cascade of dysregulation, a kind of internal noise in the brain.
Okay, I think I follow that. Underactive brakes lead to overactive downstream systems.
That's a good way to put it. This hypothesis has spurred significant research into investigational glutamatergic agents. For example, scientists are exploring metabotropic glutamate receptor agonists, particularly those targeting MGLRR23, which inhibit glutamate release presynaptically.
So trying to dampen the system further up.
Correct. While some early trials with specific agents like LY2X00023 showed promise, others like pomeglumitid methynomyl, unfortunately, failed in later trials. However, the broader class of MBOR23 agonists is still actively being explored, especially for their potential to address the negative and cognitive symptoms of schizophrenia, which are so challenging to treat with current medications. Another promising avenue is glycine site modulation. The NMDA receptor requires glycine for full activation.
Right.
Although trials with high doses of glycine itself haven't been consistently convincing, current research is intensely focused on glycine transport inhibitors, or GLyT1 inhibitors.
Trying to boost glycine levels near the receptor.
Exactly. One such agent, bitopertin, initially showed promise in improving negative symptoms when used alongside standard antipsychotics, but unfortunately, subsequent large trials were disappointing. However, another GLyT1 inhibitor called sarcosine, or N-methylglycine, has shown more consistent benefits in improving both negative and positive symptoms of schizophrenia when combined with standard antipsychotics in both acutely ill and chronic patients. So there's still hope there. Then we have amphetamines, a class of drugs that essentially potentiate or amplify the currents mediated by AMPA-type glutamate receptors.
Boosting a different type of glutamate receptor.
Yes. In behavioral studies, amphetamines have been effective in correcting behaviors in various animal models of schizophrenia and depression. They also appear to be neuroprotective, partly by mobilizing crucial growth factors, like the brain-derived neurotrophic factor, or BDNF, which supports the health and growth of neurons.
But where does that stand now?
Well, while no glutamate-specific agents are currently approved for schizophrenia, several are in late clinical testing. It signifies that this is a very active, hopeful, and promising area of research for future treatments that might go beyond just addressing the positive symptoms.
So we've mapped the incredibly complex landscape of the brain's involvement in schizophrenia. Now let's get granular. What are these drugs chemically, and how do they actually interact with these intricate systems we've just discussed at a molecular level?
Okay, yeah, let's dive into the actual drugs. Antipsychotics represent a remarkably diverse group of chemical structures, reflecting decades of scientific discovery and innovation. We broadly categorize them into first-generation, often called typical, and second-generation, or atypical, drugs.
Right, the typicals and the atypicals.
Exactly. First, let's talk about the first-generation typical antipsychotics. These largely fall into a few chemical families. Phenothiazine derivatives. These are further divided based on their side chains. The aliphatic derivatives, like chlorpromazine, were among the first. They're generally less potent and known for causing more sedation and weight gain.
Okay.
Similarly, piperidine derivatives, such as thioridazine, also tend to be less potent with similar side effects. In contrast, piperazine derivatives, which include fluphenazine, perfenazine, and trifluoprazine, are more potent and exhibit more selective pharmacological effects.
More targeted, less broad.
Generally, yes. Now, there was a notable but ultimately flawed NIMH-funded study called KATIE that suggested perfenazine was as effective as most atypicals.
I remember hearing about that.
Yeah, it caused a stir. But it's crucial to understand that this study had significant methodological flaws in its design, execution, and analysis, issues with the dosage of newer drugs, including treatment-resistant patients, encouraging switching medications, which ultimately limited its impact on clinical practice. The consensus remained that newer agents offered advantages, especially regarding side effects. Thiaxanthine derivatives? Thiaxine is a prime example here. Butyrophenone derivatives. Haloperidol is the big one here, most widely used first-gen, and it stands out with a very different chemical structure from the phenothiazines.
Right.
Butyrophenones tend to be more potent and cause fewer autonomic effects, but importantly, they carry a significantly greater risk of extrapyramidal side effects, EPS.
Which brings us back to the case study.
Exactly. Remember our 19-year-old on haloperidol who developed intolerable adverse effects, including severe akathisia. That's a classic, direct example of haloperidol's high EPS risk in action. Miscellaneous structures. This group includes drugs like chemoside and molindone, which don't offer any major efficacy advantages over the older typicals. Okay, moving on to the second-generation atypical antipsychotics. These have really become the dominant class now, mainly due to their improved side effect profiles and broader efficacy. Prototypes and examples. Clozapine is considered the foundational prototype for this class.
The original atypical.
Precisely. And the list has grown significantly to include asenapine, olanzapine, quetiapine, paliperidone, risperidone, ziprasidone, brexpiprazole, cariprazine, lurasidone, and aripiprazole, among others. It's interesting that paliperidone is actually the active metabolite of risperidone, meaning it's what risperidone breaks down into in the body. Complex pharmacology. These drugs generally possess a more intricate pharmacology compared to first-generation agents. Their distinguishing feature is a greater ability to modulate 5-HT2A serotonin receptor activity compared to their direct interference with D2 dopamine receptors.
That key serotonin link again?
Yes. Most also act as partial agonists at the 5-HT1A receptor, which is thought to produce synergistic effects with their 5-HT2A antagonism, contributing to their unique profiles. Many also act as antagonists at 5-HT6 or 5-HT7 receptors, further illustrating their multi-receptor action. They're hitting multiple targets, sulpride and sulpiride. While not approved in the USA, these represent another atypical class. They have equivalent potency for D2 and D3 receptors and are also 5-HT7 antagonists. They successfully dissociate EPS from antipsychotic efficacy, but cause marked increases in serum prolactin and aren't as free of the risk of tardive dyskinesia as clozapine and quetiapine. Cariprazine. This is a particularly unique second-generation agent approved in the USA in 2015. Beyond its D25-HT2 antagonism, it also acts as a partial agonist at the D3 dopamine receptor with a notable selectivity for D3.
D3 specifically, why is that important?
Well, this D3 selectivity is hypothesized to be associated with greater effects on the negative symptoms of schizophrenia, which are notoriously difficult to treat. Lastly, we have the emerging class of glutamatergic antipsychotics, which are still investigational. As we said, no glutamate-specific agents are currently approved for schizophrenia, but several are in late clinical testing. These include the GLI-T1 inhibitors like bitopertin and sarcosine, and various metabotropic glutamate receptor agonists. They're being explored for potential to target negative and cognitive symptoms, representing a hopeful future direction.
Fascinating how diverse these chemical structures are. So once these drugs are prescribed and enter the body, what actually happens to them? How do they reach their targets, and why do some of them seem to have such long-lasting effects?
Right. That brings us to pharmacokinetics, the study of what the body does to the drug. Let's break it down. First, absorption and distribution. Most antipsychotic drugs are readily but often incompletely absorbed after oral administration. Many undergo significant first-pass metabolism in the liver.
Meaning less of the drug actually gets into the bloodstream initially.
Correct. For example, an oral dose of chlorpromazine might have only about 25-35% systemic availability, while haloperidol, with less first-pass metabolism, reaches around 65%. Once absorbed, these drugs are highly lipid-soluble, meaning they easily cross cell membranes and are extensively protein-bound, typically 92-99%.
So they spread widely.
Yes, they distribute widely throughout the body, shown by their large volumes of distribution, usually more than 7 liters per kilogram. Now, a crucial point here is that their clinical duration of action is often much longer than their plasma half-lives might suggest.
Why is that?
It's largely due to the prolonged occupancy of D2 dopamine receptors in the brain by these drugs, particularly the typical antipsychotics. They stick around on the receptors. For instance, metabolites of chlorpromazine can still be detected in urine weeks after the last dose.
Weeks? Wow.
Yeah. Even more dramatically, long-acting injectable forms can block D2 receptors for as long as 3 to 6 months after a single injection.
Incredible persistence.
It is. And this relates to relapse. For stable patients with schizophrenia who stop their medication, the average time to relapse is around 6 months. Clozapine is a distinct exception here. Relapse after discontinuation is usually very rapid and severe, so it should never be stopped abruptly unless there's a serious, life-threatening medical necessity like myocarditis or granulocytosis. Next, let's consider metabolism. Most antipsychotic drugs are almost entirely metabolized by liver microsomal cytochrome P450 enzymes. The major isoforms involved are CYP2D6, CYP1A2, and CYP3A4.
Which means potential drug interactions.
Exactly. It's an important clinical consideration, especially when combining antipsychotics with other psychotropic drugs or with agents that inhibit P450 enzymes like certain antifungals, ketoconazole being a common example. However, it's generally good news that at their typical clinical doses, antipsychotics usually do not significantly interfere with the metabolism of other drugs.
Now, for what many consider the core of pharmacology, how these drugs actually change brain chemistry, what are their direct effects, and how do they achieve their therapeutic and sometimes adverse outcomes at the cellular level?
This is pharmacodynamics, understanding what the drug does to the body. Early phenothiazine antipsychotics, like chlorpromazine, have a very broad range of effects on the central nervous system, the autonomic nervous system, and the endocrine system.
Getting lots of targets.
Very much so. While their efficacy in treating psychosis is primarily driven by blocking D2 dopamine receptors, many of their adverse actions stem from blocking a wider range of receptors, including alpha-renoceptors, muscarinic acetylcholine receptors, H1 histaminic receptors, and 5-HT2 serotonin receptors. To truly grasp their mechanism, we need to understand the 5 key dopaminergic systems or pathways in the brain. These are crucial for both the pathophysiology of schizophrenia and how antipsychotic drugs work. 1. The mesolimbic mesocortical pathway. This pathway originates in the ventral tegmentum and projects to the limbic system and neocortex. This system is most closely related to behavior, and importantly, the manifestation of positive psychotic symptoms like hallucinations and delusions.
Okay, the psychosis pathway.
Largely, yes.
Yeah.
The nigrostriatal pathway. Consisting of neurons that project from the substantia nigra to the dorsal striatum, including the caudate and putamen, this system is fundamentally involved in the coordination of voluntary movement.
And this is the key one for side effects.
Critically important, yes. Blockade of the D2 receptors in this specific pathway is directly responsible for the extrapyramidal side effects, EPS, that we discussed earlier, like the severe akathisia our 19-year-old patient experienced with haloperidol. 3. The tuberoinfundibular system. This arises in the arcuate nuclei of the hypothalamus and releases dopamine into the pituitary portal circulation. Physiologically, the dopamine released here inhibits prolactin secretion from the anterior pituitary.
Leading to hormonal side effects if blocked.
Exactly. 4. The medullary periventricular pathway. This system involves neurons in the motor nucleus of the vagus, though its exact projections aren't fully defined. It's thought to potentially be involved in eating behavior. 5. The inserto-hypothalamic pathway. This pathway forms connections from the medial zona incerta to the hypothalamus and amygdala. In animal models, it appears to regulate the anticipatory motivational phase of certain behaviors, so the understanding of dopamine receptors and their effects has been central. After dopamine was identified as a neurotransmitter in 1959, it was shown that its effects on central synapses electrical activity and the production of the second messenger CAM-MP could be blocked by antipsychotics. This led to the foundational dopamine hypothesis in the 1960s, suggesting these drugs were dopamine receptor antagonists. Antipsychotic action is now thought to be produced, at least partly, by their ability to block dopamine effects, particularly through D2 receptors, which inhibit adenyl cyclase activity in the mesolimbic system. Currently, 5 dopamine receptors have been identified, categorized into 2 families. The D1-like family, D1, D5, increases CAM-MP, but surprisingly, the therapeutic potency of antipsychotics doesn't correlate with their affinity for D1 receptors, and selective D1 antagonists haven't proven effective as antipsychotics.
So D1 isn't the main target for efficacy?
Doesn't seem to be. The D2-like family, D2, D3, D4, decreases CAM-MP. Crucially, D2 receptors, found pre- and postsynaptically in areas like the caudate putamen and nucleus accumbens, are primarily blocked by first-generation antipsychotics in a stereoselective manner. Their binding affinity to D2 receptors is very strongly correlated with both clinical antipsychotic efficacy and the potential for extrapyramidal side effects.
A clear dose-response relationship there.
Yes. In vivo imaging studies show that for antipsychotic efficacy, typical antipsychotics require at least 60% occupancy of striatal D2 receptors. However, some second-generation antipsychotics like clozapine and olanzapine are effective at lower D2 occupancy levels, 30 to 50%, likely because they also have high occupancy of 5-HT2A serotonin receptors.
So they achieve efficacy differently.
Right. And first-generation antipsychotics typically produce EPS when striatal D2 receptor occupancy reaches 80% or higher. Now, a fascinating exception is aripiprazole. Pete's studies show very high D2 receptor occupancy with this drug, yet it does not cause EPS.
Why not? That seems contradictory.
Because it is a partial D2 receptor agonist, it doesn't fully block the receptor, it partially activates it, preventing the overblockade that leads to EPS while still modulating the system.
Ah, a more nuanced interaction.
Exactly. Aripiprazole also gains therapeutic efficacy through its 5-HT2A antagonism and possibly 5-HT1A partial agonism, showcasing a more complex approach to receptor modulation. It has not been convincingly demonstrated that antagonism of any dopamine receptor other than the D2 receptor plays a significant role in the antipsychotic action of currently approved drugs. However, as we keep saying, most of the newer atypical and some traditional antipsychotic agents have a higher affinity for the 5-HT2A receptor than for the D2 receptor, emphasizing the crucial role of serotonin. Let's also consider novel pharmacodynamic targets, which represent the cutting edge and future of treatment. While currently available antipsychotics predominantly act on the D2 receptor, there are at least 2 agents with little or no affinity for D2, clozapine and pimavanserin.
Pimavanserin, you mentioned that for Parkinson's psychosis.
Yes, exactly. It's primarily a 5-HT2 antagonist, approved for psychosis and Parkinson's disease, and, notably, has no dopamine antagonist properties, so it causes no EPS. Clozapine is also a potent 5-HT2 antagonist with differential effects on D1-D4. The current limitation is that while existing antipsychotics are excellent for positive symptoms, they often have intolerable side effects and are less effective for negative and cognitive symptoms, which are often the most debilitating for patients.
The unmet needs.
Precisely. This is why there's immense excitement around drugs in late-stage development with truly novel pharmacodynamic profiles. For instance, xanomeline, a muscarine M1/M4 agonist.
Targeting acetylcholine receptors.
Yes. It has shown efficacy in schizophrenia and crucially lacks the EPS and metabolic side effects commonly seen with first- and second-generation antipsychotics. It has also shown benefit for cognitive and potentially negative symptoms, with FDA review expected in 2023.
Very promising.
And another highly promising agent is ulotaront, a traceamine-associated receptor 1, TAR1 agonist. It too has shown efficacy in schizophrenia, lacks EPS and metabolic side effects, and may be particularly beneficial for negative symptoms. It has received FDA breakthrough designation, with approval expected by 2024. These represent real hope for patients who don't respond well to current treatments or struggle significantly with their side effects, potentially offering new pathways to better quality of life.
That's a deep dive into the how at a molecular level. This is where the unique fingerprint of each drug emerges. How do their specific receptor interactions explain their distinct effects and side effects?
That's a critical question because while almost all effective antipsychotic drugs block D2 receptors, the degree of this blockade relative to their actions on other receptors varies considerably. This differential receptor affinity is the key to understanding their individual profiles, why one drug might cause more sedation, another more weight gain, and another more movement problems.
Right, the specific side effect profile.
Exactly. For example, by looking at the specific receptor binding affinities, we can deduce a lot. Chlorpromazine, one of the earliest, has roughly equal affinity for alpha-1 adrenergic and 5-HT2A serotonin receptors, slightly more than for D2 dopamine receptors, and even less for D1. This broad-spectrum binding contributes to its wide array of side effects, including sedation and orthostatic hypotension from alpha-1 blockade.
Okay, so hitting alpha-1 causes those issues.
Often, yes. Haloperidol, a high-potency typical, is primarily a D2 blocker, with significantly higher affinity for D2 than any other receptor. This D2 selectivity is precisely why it's so effective for positive symptoms, but also why it has a high risk of EPS.
Makes sense.
Clozapine, the prototype atypical, stands out. It has higher affinity for D4 and alpha-1 receptors than for D2 and D1, and very strong 5-HT2A affinity. This unique profile, particularly its relatively weaker D2 binding, combined with strong 5-HT2A blockade, contributes to its low EPS risk and unique efficacy in treatment-resistant cases.
A very different fingerprint.
Very different. Olanzapine is somewhat similar to clozapine, with very high affinity for 5-HT2A and H1 histamine receptors than D4, D2, and alpha-1. Its high H1 affinity explains its sedating and weight gain properties.
H1 blockade equals sedation and weight gain.
Often a strong contributor, yes. Aripiprazole has a very balanced profile, showing roughly equal high affinity for D2 and 5-HT2A, followed by D4, alpha-1, and H1. Remember, its D2 action is as a partial agonist, which is key to its lower EPS risk. Couchepine has yet another pattern, with highest affinity for H1 histamine receptors, then alpha-1 muscarinic, M13, D2, and 5-HT2A. Its strong H1 and alpha-1 blockade explain why it's very sedating and can cause orthostatic hypotension, while its relatively lower D2 affinity contributes to lower EPS risk. The key insight from these different fingerprints of drug action is that while nearly all effective antipsychotics work on D2 receptors, the newer atypical ones achieve their better side effect profile and often broader efficacy by also strongly affecting serotonin receptors, especially 5-HT2A, and by having a more nuanced interaction with dopamine receptors themselves, like aripiprazole being a partial agonist.
So it's the balance of receptor actions that matters.
Exactly. That's the real game changer in terms of minimizing those distressing movement side effects. Current research is actively searching for new compounds that are even more selective for the mesolimbic system to minimize EPS, or that target other central neurotransmitter systems, such as those involving acetylcholine and excitatory amino acids, which are being explored as completely new targets for antipsychotic action. And here's a crucial connection. While it's been difficult to pinpoint one receptor responsible for antipsychotic efficacy, the differences in receptor effects of various antipsychotics do explain many of their toxicities. In particular, extrapyramidal toxicity appears to be consistently associated with a high potency for D2 receptor blockade.
Okay, the link's clear.
Beyond receptor binding, these drugs have broader physiological effects that impact the patient experience. Let's look at their psychological, EEG, endocrine, and cardiovascular effects. First, psychological effects. For individuals who don't have psychosis, taking older typical antipsychotics can be quite unpleasant.
Right, not like taking a sedative.
Not at all. They can induce mild to severe EPS, intense akathisia, that profoundly distressing, uncontrollable inner restlessness, along with sleepiness, general restlessness, and various autonomic effects like dry mouth. In healthy individuals, even low doses of antipsychotics can impair performance on psychomotor and psychometric tests, affecting things like reaction time and cognitive processing. However, in stark contrast, psychotic individuals often show improvement in their performance as their psychosis is alleviated, highlighting the therapeutic effect.
Interesting. What about cognition in patients?
The ability of second-generation antipsychotics to improve cognitive domains in patients with schizophrenia and bipolar disorder is still a topic of ongoing research and maybe some controversy, but some individuals do experience marked improvement. For that reason, cognition should be assessed in all patients with schizophrenia and a trial of an atypical agent considered, even if positive symptoms are well controlled by first-generation agents. Regarding electroencephalographic EEG effects, antipsychotic drugs typically shift EEG frequencies, generally slowing them down and increasing synchronization, meaning the brainwaves become more uniform. This slowing, or hypersynchrony, can sometimes be focal or unilateral, which, if not recognized, might lead to a mistaken diagnosis.
Like a seizure focus.
Potentially, yes. While some antipsychotic agents like clozapine can lower the seizure threshold and induce EEG patterns typical of seizure disorders with careful dosage titration, most can be used safely even in patients with epilepsy. In terms of endocrine effects, older typical antipsychotics, along with risperidone and paliperidone, are known to cause elevations in prolactin levels.
Hyperprolactinemia.
Yes. This can lead to the amenorrhea-galactorrhea syndrome, where women stop menstruating and produce breast milk, and infertility in women, along with loss of libido, impotence, and infertility in men. It can also contribute to osteoporosis in the long term.
Significant side effects.
Very significant. In contrast, newer atypical antipsychotics such as olanzapine, quetiapine, aripiprazole, and brexpiprazole cause no or minimal increases in prolactin. This is a major advantage, reflecting their diminished D2 antagonism and thus a reduced risk of EPS and tardive dyskinesia. Finally, let's discuss cardiovascular effects. Low-potency phenothiazines frequently cause orthostatic hypotension, that sudden drop in blood pressure when you stand up in tachycardia, or rapid heart rate. These are predictable, given their autonomic actions. Abnormal electrocardiograms have been observed, especially with thiordazine, showing prolongation of the QT interval and abnormal ST segment and T-waves configurations. These changes are typically reversible upon drug withdrawal. However, due to its association with a serious heart rhythm disorder called torsades de pointe and an increased risk of sudden death, thiordazine was removed from the branded market in 2005 and is now used as a second-line agent only in very specific circumstances.
What about the newer ones and QT prolongation?
Well, prolongation of the QT or QTC interval has received a lot of attention, leading to warnings for ziprasidone and quetiapine. However, it's important to note there's no strong evidence that this translates into an increased incidence of dangerous arrhythmias in actual clinical practice. A large 20,000 patient study comparing ziprasidone to olanzapine showed minimal or no increased risk of torsades de pointe or sudden death with ziprasidone.
Okay, so the risk might be lower in practice than the label suggests.
It seems so, based on that large study. But it's also critical to remember that atypical antipsychotics are broadly associated with a metabolic syndrome weight gain, elevated blood sugar, unhealthy lipid profiles, all of which can increase the long-term risk of coronary artery disease, stroke, and hypertension. That's a major ongoing concern.
Now that we know what these drugs are and how they work at a fundamental level, let's bridge that knowledge to their real-world impact. Beyond schizophrenia, what are they actually used for in the clinic, and how are these choices made?
Right, the practical side. While schizophrenia remains a primary indication, it's a crucial insight that in the last decade, the use of antipsychotics in mood disorders, particularly type 1 bipolar disorder, psychotic depression, and even treatment-resistant unipolar depression, has actually surpassed their use in schizophrenia.
Really, more use in mood disorders now.
Yes, it's a significant trend. For specific manifestations like catatonic forms of schizophrenia, the initial management typically involves intravenous benzodiazepines for rapid symptom control, with antipsychotics brought in later to treat any residual psychotic components. It's also important to acknowledge that many patients show little response to treatment for schizophrenia, and virtually none show a complete cure, highlighting the persistent challenge. Antipsychotics are also essential for schizoaffective disorders. These conditions combine features of both schizophrenia and major mood disorders, and increasingly, experts view them as part of that continuum with bipolar psychotic disorder.
Right.
The psychotic aspects necessitate treatment with antipsychotic drugs, often in combination with other agents like antidepressants, lithium, or valproic acid, depending on the predominant mood symptoms. In bipolar affective disorder, the manic phase very frequently requires treatment with antipsychotic agents. Although for milder cases, lithium or valproic acid supplemented with potent benzodiazepines like lorazepam or clonazepam can sometimes suffice.
But often antipsychotics are needed for acute mania.
Very often. Controlled trials strongly support the efficacy of second-generation antipsychotics as monotherapy during the acute manic phase. Furthermore, several second-generation antipsychotics are now FDA-approved for long-term maintenance treatment in bipolar disorder, appearing to be particularly effective in preventing manic episodes, though less so for depressive ones. As mania subsides, the antipsychotic may be tapered off, though maintenance with atypical antipsychotics is increasingly common. An increasingly common and immensely important use of antipsychotics is in the monotherapy of acute bipolar depression and as adjunctive treatment for unipolar depression.
Treating the lows, not just the highs.
Exactly. For bipolar depression, several antipsychotics are now FDA approved, including quetiapine, lorazepam, cariprazine, lumateperone, and a combination of olanzapine with fluoxetine. These antipsychotics appear more consistently effective than traditional antidepressants in bipolar depression and crucially do not increase the risk of inducing mania or increasing the frequency of bipolar cycling.
That's a key advantage over some antidepressants in bipolar.
It is. Similarly, for unipolar depression, aripiprazole, coquipine, pexpiprazole, and olanzapine with fluoxetine are approved as adjuncts. This is significant because, while many drugs are combined with antidepressants, antipsychotics are the only class formally evaluated and approved by the FDA for this specific purpose. They consistently show benefit in improving the overall antidepressant response for those with residual symptoms or partial remission. For acute agitation, intramuscular IM formulations of antipsychotics are often employed, particularly when agitation is associated with bipolar disorder or schizophrenia.
For rapid control.
Yes. Older drugs like haloperidol have a long history of use in settings like ICUs for delirium and post-surgical agitation. The IM forms of ziprasidone, olanzapine, and aripiprazole have been shown to rapidly improve agitation, typically within 1 to 2 hours, and with fewer extrapyramidal symptoms than typical agents like haloperidol.
Any newer options for agitation?
Yes. A novel agent recently approved is sublingual dexmedetomidate, an analog of an anesthetic. This sublingual film doesn't carry the EPS risks of acute antipsychotics, with common side effects being sedation and dry mouth, a different mechanism altogether. Other established indications for antipsychotic use include Tourette syndrome, where they can help manage Javix. They're sometimes used for disturbed behavior in Alzheimer's disease, but it's important to note that controlled trials generally haven't demonstrated strong efficacy for this, and both second-generation and some first-generation antipsychotics have been associated with increased mortality in these vulnerable patients, so use cautiously there.
Right, and definitely not for things like withdrawal or simple anxiety.
Correct. Antipsychotics are not indicated for the treatment of various withdrawal syndromes, such as opioid withdrawal, or for general anxiety and minor emotional disorders, where anti-anxiety sedatives are preferred due to a better safety and acceptability profile. Misuse in those areas is inappropriate. Parkinson's disease psychosis presents a unique challenge because the medications used to treat Parkinson's motor symptoms, like levodopa, can actually exacerbate psychotic symptoms.
While the antipsychotics worsen the motor symptoms, a real bind.
Exactly. A new type of antipsychotic, pimavanserin, was approved in 2016 specifically for psychosis in Parkinson's disease. It's a selective serotonin inverse agonist, meaning it has no dopamine antagonist properties, and therefore, crucially, is not associated with EPS, making it a valuable tool in this complex patient population. Pimavanserin is also being investigated as an adjunctive treatment in schizophrenia itself. Finally, for autism spectrum disorders, ASD, risperidone and aripiprazole are approved for managing irritability and behavioral discontrol in ASD patients. However, it is absolutely critical to understand that no medications are known to treat or correct the core symptoms of ASD itself. These medications manage specific behavioral challenges.
An important distinction. So beyond those direct psychiatric applications, do these powerful medications have any other, perhaps surprising, uses in the clinic?
Yes, several non-psychiatric indications exist, leveraging their broad receptor effects. For example, most older first-generation antipsychotic drugs, with the exception of thiordazine, exhibit a strong antiemetic effect.
Anti-nausea.
Yes, highly effective at preventing nausea and vomiting. This action is due to their dopamine receptor blockade, both centrally in the chemoreceptor trigger zone of the medulla and peripherally on receptors in the stomach. In fact, some drugs like prochlorperazine and benzkinamide are marketed solely as antiemetics. Additionally, some phenothiazines with shorter side chains possess considerable H1 receptor blocking action. This property makes them useful for relieving pruritus or itching and can also contribute to sedation. Promethazine, for instance, is commonly used as a preoperative sedative due to this effect.
Okay.
Lastly, the butyrophenol droperidol is used in combination with the opioid fentanyl in a technique called neural leptanesthesia, providing profound sedation and analgesia. However, droperidol has a dose-associated risk of QT prolongation and has been removed from some markets due to safety concerns.
With such a wide array of options and a complex understanding of their mechanisms, how do clinicians make the best choice for an individual patient? Is it simply about which one is most effective?
No, it's definitely not just about efficacy, though that's obviously crucial. The choice among antipsychotic drugs is a nuanced clinical decision based mainly on a careful consideration of their distinct adverse effect profiles, any potential subtle differences in efficacy for specific symptom clusters, and very practical considerations like cost and formulary availability.
Right, real-world factors.
Exactly. Because older drugs like chlorpromazine and haloperidol are still commonly used, especially in public health systems, it's vital for professionals to be familiar with their profiles alongside all the newer compounds. Now, for approximately 70% of patients with schizophrenia and a similar proportion with bipolar disorder exhibiting psychotic symptoms, first- and second-generation antipsychotic drugs are broadly equally effective for treating positive symptoms like hallucinations and delusions.
So for those core symptoms, efficacy is often similar.
Often, yes. However, the evidence strongly favors second-generation drugs for several key advantages. They generally offer greater benefit for those challenging negative symptoms, and for cognitive function, they carry a significantly diminished risk of tardive dyskinesia and other forms of EPS, and they lead to lesser increases in prolactin levels. These advantages often make them the preferred first-line choice. A very significant consideration when choosing an antipsychotic is the potential for metabolic side effects: weight gain, increases in lipids, the risk of developing diabetes.
The metabolic syndrome issue.
Yes. Some second-generation drugs cause more pronounced weight gain and lipid increases than even some first-generation drugs. A small but concerning percentage of patients can develop diabetes mellitus, most often seen with clozapine and olanzapine.
So which ones are better or worse metabolically?
Generally, ziprasidone causes the least weight gain. Risperidone, loracidone, brexpiprazole, paliperidone, and aripiprazole typically produce smaller increases. Asenapine and quercetin have an intermediate effect. However, clozapine and olanzapine frequently result in substantial increases in both weight and lipids. So these drugs are often reserved for specific, compelling indications where their unique efficacy outweighs these risks. This brings us to clozapine's unique role. Despite its metabolic side effects and the need for rigorous monitoring, clozapine is often considered a second-line treatment unless there's a specific strong indication.
Mainly because it works when others don't.
Precisely. It's uniquely effective in the majority of patients with schizophrenia who are refractory, meaning unresponsive to other drugs. This often requires sustained, high doses, typically between 300 and 900 milligrams per day, for up to 6 months to see a full response. High-dose olanzapine, maybe 30-45 milligram, might also be efficacious in these refractory cases.
And it has another unique benefit.
Yes, crucially, clozapine is the only second-generation antipsychotic approved to reduce suicide risk in patients with schizophrenia. Therefore, patients with schizophrenia who have made life-threatening suicide attempts should be seriously evaluated for switching to clozapine.
But it has major downsides, too.
It does. Its use is significantly limited by the risks of granulocytosis, that dangerous drop in white blood cell count, and seizures, which necessitate strict monitoring protocols and prevent its more widespread adoption as a first-line treatment. In terms of overall response and tardive dyskinesia risk, newer antipsychotics have shown superiority over haloperidol in some trials. Their generally superior adverse effect profile and low to absent risk of tardive dyskinesia strongly suggests that these newer agents should be the first line of treatment whenever possible.
And cost is becoming less of an issue.
Yes. The good news is that generic forms of many second-generation drugs, clozapine, olanzapine, aripiprazole, risperidone, quetiapine, have become available, significantly reducing cost as a barrier and making them more widely accessible. Ultimately, the best guide for selecting a drug for an individual patient is almost always their history of past responses to medications.
What worked before, what didn't, what side effects occurred.
Exactly. At present, while clozapine is typically reserved for those who have failed other options, drugs like risperidone, olanzapine, and quetiapine are widely used due to their improved adverse effect profiles. And currently, aripiprazole is the most commonly prescribed second-generation antipsychotic in the USA, largely due to its relatively favorable side effect profile and successful market introduction. Let's discuss dosage, parenteral preparations, and schedules.
There's a broad range of effective dosages among various antipsychotic agents, and they generally possess substantial therapeutic margins, meaning the gap between a therapeutic dose and a toxic dose is wide. Most antipsychotics, with the exceptions of clozapine and perhaps olanzapine, are considered of equal efficacy in broadly selected groups of patients.
Meaning if one doesn't work, another might.
Correct. Clinicians may need to try several drugs to find the most effective one for an individual. Patients who are refractory to 2 or 3 antipsychotic agents at substantial doses are prime candidates for treatment with clozapine or high-dose olanzapine, with these options offering response rates of 30–50% in previously unresponsive patients. In such severe cases, the increased risk of clozapine can be well justified by the potential for profound benefit. For specific dose relationships, clinical references provide guidelines like chlorpromazine 100,000 mg a day, haloperidol 260 mg a day, clozapine 300–600 mg a day, just as examples. For rapid initiation or for maintenance in non-compliant patients, parenteral preparations are invaluable.
Inject.
Yes, well-tolerated injectable forms of high-potency older drugs like haloperidol and flufenazine exist. Since parenterally administered drugs often have greater bioavailability than oral forms, the injectable doses should be only a fraction of what would be given orally. Additionally, a significant advancement has been the development of newer, long-acting injectable LAI second-generation antipsychotics, including formulations of risperidone, olanzapine, aripiprazole, and paliperidone.
The LAIs, are they better tolerated?
For some patients, these newer LAI drugs may be better tolerated and offer superior compliance advantages compared to the older depot injectables. They're a major tool now. Regarding dosage schedules, antipsychotic drugs are often initially given in divided daily doses with gradual titration to an effective dosage. Clinicians typically start at the low end of the dosage range and try that for at least several weeks. Once an effective daily dosage has been determined, doses can often be consolidated and given less frequently, sometimes even once daily, typically at night for more sedating medications like quetiapine or olanzapine to improve patient compliance and convenience. Finally, maintenance treatment. A very small minority of schizophrenic patients may fully recover from an acute episode and not require further drug therapy for prolonged periods. However, for most, the choice is between increasing doses as needed or adding other drugs for exacerbations versus continuous maintenance treatment at a full therapeutic dosage.
A difficult decision.
It is. It often depends on social factors like family support, knowing relapse signs, and access to care. On average, for stable schizophrenia patients who discontinue their antipsychotic medication, the time to relapse is about 6 months, highlighting the need for ongoing treatment for most. The practice of drug combinations, or polypharmacy, is quite widespread in clinical psychiatry, even though it can complicate the evaluation of individual drug efficacy.
Combining antipsychotics or adding other drug types.
Both. There's increasingly experimental data supporting some combinations. For instance, tricyclic antidepressants, or more commonly SSRIs, are often used with antipsychotic agents to address symptoms of depression that may complicate schizophrenia, though the evidence for the usefulness of this specific combination while practiced is sometimes minimal. Electroconvulsive therapy, ECT, is a powerful and useful adjunct to antipsychotic drugs, not only for treating severe mood symptoms, but also for rapid control of severe positive symptoms. ECT can even augment clozapine when maximum doses of clozapine alone are ineffective.
Interesting. But not all combinations help.
Right. It's been shown that simply adding risperidone to clozapine does not provide additional benefit, suggesting some combinations are more effective than others. Lithium, or valproic acid, is sometimes added to antipsychotic agents, and this combination can be beneficial for patients who don't respond fully to antipsychotics alone. There's some evidence that lamotrigine may be even more effective than other mood stabilizers for this specific indication. It's often uncertain whether successful combination therapy in these cases represents a misdiagnosed case of mania or schizoaffective disorder.
Blurring the diagnostic lines.
Exactly. Lastly, benzodiazepines can be very useful for patients experiencing anxiety symptoms or insomnia that are not adequately controlled by antipsychotics alone, providing symptomatic relief without adding to the antipsychotic burden.
This is a critical area for anyone understanding these medications. The side effects. Some are minor and manageable, while others can be severe or even life-threatening. What are the most important adverse reactions we need to be acutely aware of as professionals?
Absolutely crucial. Managing adverse reactions is paramount for both patient well-being and medication adherence. Let's start with behavioral and neurologic effects.
The older, typical antipsychotic drugs can be quite unpleasant to take, which often leads to poor compliance.
That subjective feeling matters.
It really does. Patients may experience a pseudodepression, which is often due to drug-induced akinesia, a reduction in voluntary movement and spontaneous activity. This typically responds to cautious treatment with anti-Parkinsonism drugs or a dose reduction. Other forms of pseudodepression might occur if a patient on a partially remitted dose is receiving too high dosage, in which case lowering the dose can alleviate symptoms. Toxic confusional states can also occur, particularly with very high doses of drugs that have prominent antimuscarinic actions, leading to disorientation and confusion. The neurologic effects, specifically extrapyramidal symptoms, EPS, are a major and frequently distressing concern. These include early reactions during treatment, Parkinson's syndrome, mimicking Parkinson's disease like tremors, rigidity, slowed movements, treatable with conventional anti-muscarinic anti-Parkinsonism drugs or sometimes amantadine. It's absolutely crucial that levodopa is never used, as it can worsen psychosis. Parkinsonism may be self-limiting, so clinicians often try withdrawing anti-Parkinsonism drugs every 3 to 4 months. Akathisia, that incredibly distressing, uncontrollable inner restlessness. Remember our 19-year-old. Severe akathisia, from haloperidol, is a feeling of needing to constantly move, extremely uncomfortable. It often responds well to anti-Parkinsonism drugs or sedative antihistamines like diphenhydramine. Acute dystotic reactions, sudden, severe, often painful muscle spasms like spastic retrocollis or torticollis. They also respond rapidly to anti-Parkinsonism drugs or, often preferred, sedative antihistamines like diphenhydramine, given parenterally for rapid relief. The most important unwanted long-term effect, however, is tardive dyskinesia, TD.
The late-appearing movement disorder.
Exactly. A late-occurring syndrome of abnormal, involuntary choreothetoid movements, uncontrolled, jerky, almost dance-like motions, especially in the face, mouth, and limbs. It's thought to be caused by a relative cholinergic deficiency due to supersensitivity of dopamine receptors in the caudate putamen, the brain compensating for prolonged D2 blockade.
And it used to be very common.
Tragically high, yes. Prevalence was estimated between 20–40% of chronically treated patients before atypicals. Early recognition is vital, as advanced cases can be very difficult to reverse. If a patient develops TD, the first step is often to discontinue or slowly reduce the current antipsychotic or switch to an atypical, particularly quetiapine or clozapine, which are least likely to cause TD. A second step is to eliminate all drugs with central anticholinergic action, like anti-Parkinsonism drugs or TCAs, as these can often paradoxically worsen or unmask TD.
Now, a major revolution in TD treatment occurred recently with the approval of VMAT2 inhibitors.
New drugs specifically for TD. Yes, valbenazine in 2017 and deutetrabenazine in 2018. These drugs selectively bind to the vesicular monoamine transporter type 2, VMAT2, to reversibly decrease dopamine release. Since TD is thought to result from postsynaptic dopamine hypersensitivity, these inhibitors effectively reduce this excess signaling without causing general dopamine antagonism.
How effective are they?
Remarkably effective. In clinical trials, between 40% and 60% of patients showed significant improvement in their TD symptoms. Common side effects include fatigue, somnolence, and headaches, with less common issues like GI problems, akathisia, and QT prolongation also reported. These agents have truly transformed the prognosis for patients with TD. Finally, neurologically, seizures can occur, rare with high-potency older drugs, but de novo seizures may occur in 2 to 5% of patients treated with clozapine. Fortunately, these can usually be controlled with standard anticonvulsants, allowing clozapine continuation if benefits outweigh risk. Let's move on to autonomic, metabolic, and endocrine effects, which are critical for long-term health. Autonomic nervous system effects. Common antimuscarinic effects like loss of accommodation, dry mouth, difficulty urinating, constipation are usually tolerated. But if severe, like urinary retention, switching drugs is needed. Orthostatic hypotension or impaired ejaculation are common with drugs like chlorpromazine or mezordazine due to alpha-adrenoceptor blockade, prompting a switch to drugs with less alpha-blocking action. Metabolic and endocrine effects are particularly important to monitor closely with atypical antipsychotics. Weight gain is very common, especially with clozapine and olanzapine, requiring careful monitoring of food intake. This isn't just cosmetic, it increases health risks. Hyperglycemia and hyperlipidemia can also develop, significantly increasing the risk of cardiovascular disease. Diabetic ketoacidosis has rarely been reported.
So monitoring is key.
Absolutely. Monitor weight at each visit, fasting blood sugar and lipids every 3-6 months. Hemoglobin A1C is useful too. A triglyceride, HDL ratio 3.5 is desired. Hyperprolactinemia, as we mentioned, causes issues in women, amenorrhea, galactorrhea, infertility, osteoporosis risk, and men, loss of libido, impotence, infertility. If dose reduction ineffective, switch to an atypical that doesn't raise prolactin, like aripiprazole. Next, we have toxic or allergic reactions and ocular complications.
Rare but extremely serious, potentially fatal, uncommon with most high-potency antipsychotics, but a small but significant risk, about 1–2% with clozapine.
The white blood cell issue.
Yes, a dangerous drop, compromising the immune system. Develops rapidly, usually between weeks 6 and 18, reversible upon stopping the drug. Due to this critical risk, patients on clozapine need weekly blood counts for the first 6 months, then every 3 weeks thereafter for the entire duration of therapy.
That's intensive monitoring.
It is, and why clozapine is reserved. Other rare reactions include cholestatic jaundice and skin eruptions. For ocular complications, chlorpromazine commonly causes deposits in the cornea and lens, may accentuate normal aging, rarely impacts vision. Thiordazine is the only one known to cause retinal deposits, resembling retinitis pigmentosa in advanced cases associated with browning of vision. Maximum daily dose limited to 800 milligrams to reduce risk. Let's turn to cardiac toxicity and pregnancy considerations.
Thiordazine at doses over 300 milligrams daily, associated with T-wave abnormalities. Overdoses linked to major ventricular arrhythmias like torsades de pointe, conduction block, sudden death. Caution combined with TCAs due to additive effects.
What about atypicals in the heart?
Ziprasidone carries the greatest risk of QT prolongation. Avoid combining with other QT prolonging drugs. Clozapine sometimes associated with myocarditis, requiring discontinuation. Sudden death is common in schizophrenia, not always drug-related, and studies haven't definitively linked it to specific antipsychotics. QTc monitoring useful if values consistently exceed 500 meters. The large ziprasidone study showed minimal increased risk versus olanzapine, used during pregnancy. Generally considered relatively safe, but a small increase in teratogenic risk possible. Decision must be individualized, considering risks versus benefits and effects on neurodevelopment. Specifically for lithium, renal clearance increases during pregnancy, then reverts after delivery, posing a risk of toxicity postpartum. Lithium transfers to breast milk, 13 to 12 serum concentration. Newborn toxicity possible. Lethargy, cyanosis, poor reflexes, hepatomegaly. The link to Epstein anomaly is still researched, with recent data suggesting lower risk. Ongoing research is crucial here.
What's the most severe, life-threatening complication we might see with these medications? This sounds like a true medical emergency.
The most severe is indeed neuroleptic malignant syndrome, NMS. This occurs in patients extremely sensitive to antipsychotic EPS, essentially an extreme form.
How does it start?
Initial symptom is marked muscle rigidity. If sweating is impaired, Common with anticholinergic drugs, a fever may ensue, often reaching dangerous levels. Stress leukocytosis and high fever can misleadingly suggest infection. Autonomic instability, altered blood pressure, pulse rate is often present. Pathophysiologically, you see elevated muscle-type creatine kinase levels indicating muscle damage. It's thought to result from excessively rapid blockade of postsynaptic dopamine receptors, leading to severe EPS.
How is it treated?
Vigorous, rapid intervention. Aggressive treatment of EPS with antiparkinsonism drugs, muscle relaxants like diazepam or dantrolene. Dopamine agonists like bromocriptine can help.
Wow.
Physical cooling for fever. After recovery, switching to an atypical drug is strongly indicated due to the high sensitivity NMS reveals. Finally, let's briefly cover drug interactions and overdoses.
More important are pharmacodynamic interactions' additive effects, rather than significant pharmacokinetic ones. Additive effects with drugs causing sedation, alpha blockade, anticholinergic effects. Thioridazine and ziprasidone have quinidine-like action, so additive effects with other QT prolonging drugs. Pharmacokinetic interactions reported are generally minor.
Overdoses. Rarely fatal with most antipsychotics, unlike TCAs, except mezordazine and thioridazine no longer widely available. Symptoms progress from drowsiness to coma, maybe agitation in between, neuromuscular excitability, convulsions possible, myotic pupils, decreased reflexes, hypotension and hypothermia common, though fever can occur later, lethal effects of mezordazine to thioridazine due to ventricular tachyarrhythmias. Management is standard ABCD supportive care. Zordazine and thioridazine overdoses with arrhythmias managed like TCA overdoses.
We've just completed an incredibly detailed exploration of antipsychotics. Now, let's pivot to another class of critical medications often used in overlapping conditions, lithium and other mood stabilizers. These agents have a fascinating history and truly distinct mechanisms, making them central to the management of bipolar disorder.
Indeed. Bipolar disorder, once known as manic depressive illness, was initially conceived of as distinct from schizophrenia. However, the weight of evidence today strongly suggests a profound overlap, perhaps even a continuum of brain disorders that feature psychotic elements.
Right, that spectrum idea again.
Exactly. This means our understanding and treatments must continue to evolve, even while recognizing important pathophysiological differences that influence drug effectiveness. Let's delve into the nature of bipolar affective disorder. This condition affects between 1% and 3% of the adult population, and while it can begin in childhood, it's most often diagnosed in the third and fourth decades of life. The core features involve significant mood swings. During a manic phase, key symptoms include an expansive or irritable mood, often accompanied by hyperactivity, impulsivity, disinhibition, a diminished need for sleep, racing thoughts, and in some but not all patients, psychotic symptoms and cognitive impairment.
A very disruptive state.
Extremely. The depressive phase in bipolar patients is phenomenologically quite similar to major depression. Deeply depressed mood, diurnal variation, significant sleep disturbance, anxiety, and sometimes even psychotic symptoms. It's also common to see patients experiencing mixed manic and depressive symptoms simultaneously, which can be particularly challenging. And tragically, patients with bipolar disorder are at a very high risk for suicide. The sequence, number, and intensity of manic and depressive episodes are highly variable for each individual. The exact cause of these mood swings remains unknown, although catecholamine-related activity seems involved. Drugs increasing activity exacerbate mania. Reducing it relieves mania. Acetylcholine or glutamate might also be involved. The abrupt switch mechanism is uncertain.
And there's a strong genetic link.
Very strong familial component. Abundant evidence of genetic determination. What's particularly noteworthy is the overlap with schizophrenia genetics. Many genes increasing vulnerability to bipolar disorder are common to schizophrenia, though some are unique. Genome-wide association studies show linkage to chromosomes 8p and 13q for psychotic bipolar disorder. Candidate genes include dysbindin, DAOAG30, DISC1, and neuregulin-1, all implicated in both disorders. This powerfully underscores the notion of a spectrum.
Lithium has an almost legendary status in psychiatry. How did it even become a treatment for bipolar disorder, and what do we know about how it actually works? It still feels like a bit of a mystery, doesn't it?
It absolutely does still feel like a mystery, despite decades of research. Lithium's journey is quite unique. Used in the mid-19th century for gout, briefly and disastrously as a salt substitute in the 1940s, banned due to toxicity. The true breakthrough came in 1949. Dr. John Cade, an Australian psychiatrist, serendipitously discovered lithium's effectiveness for bipolar disorder while studying uric acid in manic patients. Controlled trials then confirmed its efficacy for the manic phase. In terms of its pharmacokinetics, lithium is a small, monovalent cation. Absorption is virtually complete within 6 to 8 hours, peak plasma levels in 30 minutes to 2 hours. Distributes in total body water, slow entry into cells, no protein binding, some sequestration in bone.
And metabolism.
None. It's almost entirely excreted, unchanged in urine. Lithium clearance is about 20% of creatinine clearance. Plasma half-life around 20 hours. Target plasma concentration is generally 0.6, 1.4 milliQL, with typical starting dosage around 0.5 millicurie day in divided doses. Now for the how, it's pharmacodynamics. Still not clearly understood, but we know it directly inhibits two crucial signal transduction pathways. One, inositol signaling suppression. Lithium inhibits impase and other enzymes in phosphoinositide recycling. Think of it as disrupting an internal chemical cycle. It blocks conversion of IP2 to IP1 and IP1 to inositol.
Leading to less raw material for signaling.
It's exactly. Depletion of free inositol and ultimately PIP2, the precursor for IP3 and DAG, key second messengers for alpha-adrenergic and muscarinic transmission. The idea is that over time, neurotransmitter effects diminish, proportionate to activity in these pathways. Manic episodes are thought to involve markedly increased activity here, so lithium dampens that overactivity. 2. Glycogen synthase kinase 3, GSK3, inhibition. GSK3 is a multifunctional protein kinase like a master switch in diverse pathways, insulin, BDNF, UYESH. Lithium inhibits GSK3, reducing phosphorylation of V-catenin, letting V-catenin accumulate and move to the nucleus. This facilitates transcription of proteins that modulate energy metabolism, provide neuroprotection, and increase neuroplasticity.
So a longer-term effect on brain structure and function.
That's the thinking, yes. Suggests a more fundamental impact on stability. It's worth noting some other mood stabilizer connections. Valproic acid, for instance, may indirectly reduce GSK3 activity and upregulate gene expression via histone acetylase inhibition. It also inhibits inositol signaling like lithium. Carbamazepine alters neuronal morphology via an inositol depletion mechanism too, but no evidence of GSK3 inhibition. These drugs might also have indirect effects on neurotransmitters. Lithium also has effects on electrolytes and ion transport. Chemically similar to sodium, can substitute for it in action potentials in Na plus Na plus exchange. Doesn't significantly affect Nes plus Nager's D2 plus exchanger or Na plus K plus Nas ATPase at therapeutic concentrations. In terms of effects on second messengers beyond inositol, lithium can inhibit norepinephrine-sensitive adenyl cyclase, may be related to antidepressant enzymatic effects. It might also uncouple receptors from their G proteins. Common side effects like polyuria and subclinical hypothyroidism may be due to uncoupling of vasopressin and TSH receptors. The major current working hypothesis is that effects on phosphoinositol turnover initiate a cascade of intracellular changes, impacting protein kinase C signaling, altering gene expression, and producing proteins for long-term neuroclastic events underlying mood stabilization. It's complex, still unfolding.
So how is lithium used in practice today? And what are the crucial aspects of managing patients on this unique medication to ensure safety and effectiveness?
In clinical pharmacology, lithium's role has evolved. For bipolar affective disorder, it was the universal preferred treatment until the late 90s. Now, a smaller percentage received lithium first line due to approval of valproate and several atypical antipsychotics.
Why the shift?
Partly due to lithium's relatively slow onset of action, often needing faster-acting antipsychotics or benzodiazepines concurrently in severe mania. Still, success rates are high, up to 80% remission for mania, 60% effective for maintenance, though may be lower in severe cases. This led to more combined treatment initially. Once mania is controlled, the antipsychotic might be withdrawn, continuing lithium benzos for maintenance. Managing the depressive phase often requires concurrent agents, like quetiapine or lurasidone. Traditional antidepressants have inconsistent utility and may even be destabilizing TCAs. SNRI is linked to precipitating mania rapid cycling in some. SSRI is less likely, but may be limited efficacy. Bupropion shows promise, but can induce mania at higher doses. Lamotrigine is effective for some bipolar depression, though results inconsistent. MAOIs work for some. Importantly, quetiapine and olanzapine fluoxetine combo are specifically approved for bipolar depression. What truly sets lithium apart is its profile. At therapeutic concentrations, largely devoid of autonomic blocking, activating, or sedating effects, unlike many others, though nausea tremor can occur. Most importantly, prophylactic use prevents both mania and depression.
A true mood stabilizer.
Exactly. Many experts believe aggressive marketing of newer drugs has inappropriately shifted focus away from lithium, despite its effectiveness for many. In terms of other applications, recurrent depression, cyclic pattern, can be controlled by lithium or imipramine. Augmenting standard antidepressant response in acute major depression is another use. Lower lithium concentrations seem adequate here. Schizoaffective disorder, often treated with antipsychotics plus lithium, antidepressants added for depression. Schizophrenia. Lithium alone rarely successful, but adding it to an antipsychotic might benefit treatment-resistant patients. Carbamazepine might work equally well here. Monitoring treatment heavily relies on serum lithium concentrations, measured 10-12 hours post-dose for steady state. Initial check 5 days after starting. Dosage adjustments based on arithmetic calculation. New dose, present, dose X, desired level, present level. Recheck after another 5 days. Once stable, measure at increasing intervals unless illness or new drug requires more checks. For maintenance treatment, the decision depends on frequency, severity of past episodes, crescendo pattern, patient compliance. Candidates.
History of O2 mood cycles or any clear bipolar diagnosis. Crucially, each recurrent cycle may leave residual damage, worsening long-term prognosis. So consensus is growing to start maintenance early. Target levels. Best results often with higher levels. For example, 0.9 FQL, though some maintained at 0.6 MQL for drug interactions. Renal clearance reduced 25% by diuretics, example thiazides, and several newer NSAIDs, not aspirin, acetaminophen. Lithium dose may need reduction. All neuroleptics tested, except maybe glutamate newer typicals, may produce more severe EPS when combined with lithium.
While incredibly effective, lithium also has a range of side effects that clinicians must carefully monitor, some of which can be quite serious. What are those key adverse effects?
Indeed, careful monitoring is crucial. Let's start with neurologic and psychiatric adverse effects. Tremor is very common, even at therapeutic doses. Often a fine tremor, alleviated by beta blockers like propranolol. Other issues: choreoathetosis, motor hyperactivity, ataxia, dysarthria, aphasia, especially at higher levels. Toxic concentrations cause mental confusion, withdrawal. Any new neurologic psychiatric symptoms mean temporarily stopping lithium and checking levels closely. Decreased thyroid function probably occurs in most to some degree, but usually reversible or non-progressive. Few develop frank goiter or hypothyroidism. Prudent to get serum TSH every 6-12 months. Nephrogenic diabetes insipidus, NDI, and other renal effects. Polydipsia, thirst, and polyuria, urination, are common, reversible. The lesion is loss of kidney responsiveness to antidiuretic hormone, NDI. Resistant to vasopressin, responds to amiloride. Long-term, reports of chronic interstitial nephritis and minimal change glomerulopathy. Some decreased GFR retorted, but marked azotemia or renal failure isn't typical. Patients must avoid dehydration. Periodic tests of renal concentrating ability needed. Edema. Common, possibly related to sodium retention. Weight gain, up to 30% of patients, isn't fully accounted for by water retention alone. Cardiac adverse effects. Bradycardic tachycardia, 6 antenna syndrome, is a definite contraindication. T-wave, flattening on ECG, often seen but questionable significance. Used during pregnancy. We cover the claimant's changes, breast milk transfer, newborn toxicity. Dysmorphogenesis, Epstein anomaly, risk seems lower than once thought, but still an area of research. Miscellaneous adverse effects. Transient acneiform eruptions, folliculitis. Leukocytosis, high white blood cells, is always present, actually used therapeutically sometimes for low counts. Overdoses. More common from therapeutic accumulation, due to low sodium diuretics, renal issues, than deliberate ingestion. Toxicity likely over 2 MOD-QL. Plasma levels might not seem that high due to tissue equilibration. Treatment. Dialysis is effective. Hemodialysis preferred.
Beyond lithium, which has clearly been a foundational treatment, what are the other major players in the mood stabilizer arena today, and how do they compare?
The toolkit has definitely expanded. Valproic acid, valproate, shows significant antimanic effects, widely used. Efficacy equivalent to lithium in early weeks of acute mania. Effective in some lithium non-responders, for example, mixed states, rapid cycling. Side effect profile allows rapid dosage increase, nausea main limit. Starting dose 750 milligrams, increasing rapidly to 1500, 2000 milligram, max 60 millikilounity. Combines well generally. First line for mania. Maintenance efficacy versus lithium unclear for all patients. Combining with lithium often tried for non-responders. Carbamazepine, a reasonable alternative to lithium, especially if lithium isn't optimal. Pharmacokinetic interactions induces CYP3A4, make it harder to use with other drugs. Mode of action unclear. Oxcarbazepine not effective. Uses acute mania, prophylactic therapy. Adverse effects generally no greater than lithium. Used alone or combined with lithium, rarely valproate in refractory patients. Dosage starts 200 milligram BID, increases to 800 to 1200 milligram. Plasma levels 314 milligram desirable. Blood dyscrasias, less a problem as mood stabilizer. Overdoses are major emergency, managed like TCAs. Lamotrigine, approved as maintenance treatment for bipolar disorder. Not effective for acute mania. Appears effective in reducing frequency of recurrent depressive cycles and may have utility in bipolar depression, though results inconsistent. Valuable for the depressive side. Investigational agents. Riluzole, neuroprotective ALS drug. Ketamine, NMDA antagonist thought to act via enhancing AMPA activity. AMPA receptor potentiators. These represent ongoing efforts to expand the toolkit, especially for those who don't respond well.
We've covered an immense amount of ground, diving deep into the pharmacology of antipsychotics and mood stabilizers. As we begin to wrap up this deep dive, let's zoom out and consider the overall impact these treatments have had and the continuing challenges that remain in this complex field.
It's absolutely vital to remember that for patients with schizophrenia, psychosocial treatment and cognitive remediation are crucial components of care that extend far beyond just medication.
Right, the whole person.
Exactly. Patients need comprehensive psychosocial support, help with daily living, housing, social activities, returning to school or work, restoring social interactions. Unfortunately, funding for this crucial component has been significantly minimized in recent years, creating a real gap.
A major problem.
It is. Case management and various forms of therapy services are absolutely vital parts of the treatment program. First episode patients particularly need this comprehensive support because they often deny their illness and struggle with medication compliance. The pill alone is simply never the complete answer. Reflecting on the benefits and limitations of drug treatment, it's clear that antipsychotic drugs have had a truly profound and revolutionary impact on psychiatric treatment. Firstly, they shifted the vast majority of patients from long-term hospitalization to community settings.
Deinstitutionalization.
Yes. For many, this provided a better, more humane life, often without physical restraints. However, we must also acknowledge that for others, this shift unfortunately led to a tragic, aimless existence on the streets rather than in institutions, highlighting systemic failures in community support. Secondly, these drugs markedly shifted psychiatric thinking to a more biologic orientation, firmly recognizing the brain's central role. Partly because of the intense research stimulated by these drugs, we now know vastly more about CNS physiology and pharmacology.
Huge scientific advances.
Huge. However, despite all this progress, schizophrenia fundamentally remains a scientific mystery, and for the individual and family, a profound personal disaster. While most schizophrenic patients get some benefit, often substantial, it's important to acknowledge that none is made well by them. They primarily manage symptoms, not cure the underlying condition. This underscores the ongoing pressing need for more effective, potentially curative, treatments and for comprehensive holistic care.
What an incredible journey into the complexities of the brain, its dysfunctions, and the remarkable efforts to bring relief through pharmacology. We've gone from historical breakthroughs to the very cutting edge of novel targets and mechanisms.
This deep dive truly reveals how deeply intertwined our understanding of the brain's chemistry is with the development of these life-changing medications. It's a field of constant discovery, where even the oldest treatments, like lithium, still hold critical and unique value, and exciting new ones are constantly emerging, offering hope for tackling even the most challenging symptoms like negative and cognitive deficits.
You now have the insights to truly understand these powerful agents, from the minute details of receptor binding to the broader human impact on patient lives. It's a level of understanding that equips you to engage with this topic like the elite professionals in the field, navigating its complexities with confidence.
And as we conclude this deep dive, it really raises an important question for you to consider. Given the intricate balance of efficacy and side effects, and the continuing mysteries of these complex brain disorders, what do you think is the next frontier in achieving true healing, moving beyond just symptom management towards a more complete restoration of well-being?
Thank you for joining us on this deep dive. Stay curious, stay informed, and we'll see you next time.